So what you see here is this is a sagittal section through an eyeball. Okay, this is the front of the eye and this is the back of the eye, and we'll start from there. Overall, the eye has a couple of different layers you need to be aware of, 3 actually. And the first layer is going to be what constitutes the white of your eye. Okay, the white of your eye is just a protective layer. Goes about 5/6 of the way all the way around. Okay, so here I'm just highlighting this in kind of a gray color. This is the white of your eye. Does anybody know what the white of your eye is called?
Sclera.
Yeah, it's your sclera. Good. Okay. So the white of your eye is called your sclera, and it's a protective layer. Real simple. White of your eye, protective layer. That's one of the protective layers of your eye. And there's another part of the eye that's considered a protective layer, and that's up here, the very front of the eye. Okay. Does anyone know what the clear front part of the eye that's a protective layer is called? Cornea. Yeah, that's your cornea. Again, your cornea is nothing more than a protective layer. So the outermost part of the eye, 2 protective layers. Sclera is the white of the eye. The cornea is the see-through part that allows light to permeate the eyeball. Cornea and sclera. Now, the next part, there's going to be a vascular layer. Outside, protective layer, the next layer in is going to be a vascular layer. And that vascular layer is here. And this is just a rich blood supply, just inside the sclera. Okay, it's going to be on the top and bottom. Almost just about halfway through the length. And this is part of the vascular layer, and this layer is called the choroid. C-H-O-R-O-I-D. And the choroid is a part of the vascular layer. Sclera, cornea, protective layer, choroid, first part of the vascular layer, and as the choroid progresses forward toward the front of the eyeball, it's going to start to thicken and turn into a muscle. Okay, and here's that muscle structure here. As it comes forward, thickens into a muscular layer, and this muscle is known as the ciliary body. Okay, and that's also, the ciliary body is part of the vascular layer. It's just a thickening of the choroid vascular layer coming forward. It's going to be the job of the ciliary body to help adjust the shape of the lens of the eye so that you can focus vision where it needs to be on the retina. Okay, sclera and cornea, protective layers, choroid and ciliary body, vascular layers. The third layer that you need to be aware of is going to be your photoreceptor layer. Photoreceptor layer is going to be here overlying the vascular layer. So these are just photoreceptor cells that exist as part of your retina. Retina, your photoreceptive layer, and then all these photoreceptive cells are connected, all their axons are connected, coming all the way down, and they exit out the back of the eyeball to form cranial nerve number 2, the optic nerve. This is nothing, the optic nerve is nothing more than a collection of the axons from photoreceptive cells of the retina. So this right here is the optic nerve. This here is your retina, and your retina is the photoreceptive layer. Okay, two different kinds of photoreceptive cells that you have in your retina. Does anybody know what those are called?
Rods and cones.
Yeah, rods and cones. Let's start with rods. The first kind is called rods. Our rods are actually 20 times more prevalent than cones. And are they good for detailed vision, or are they something else?
It's just shapes.
Yeah, shapes is kind of more of your peripheral vision. They're really good in dark light, and they're very good at detecting motion. Not fine detail, but just motion in general. So your rods are going to be, they're 20 times more prevalent than your cones, and then they're good in dim light, and they're good for peripheral vision and detecting motion. When you learn to detect peripheral vision in CP3 and neurorehab, maybe more so next year, you want to test peripheral vision way on the side by just wiggling your fingers. We'll talk about that. Okay, the other is your cones. And your cones are, did you have a question, Josh?
What motion?
The last one.
Like,
Detecting motion, any kind of motion, just movement. Yeah, the movement. Really good at, so if you're going to read fine detailed print or see details in something, you're going to use your cones. But if you're just detecting motion or anything in the periphery in your vision, you're going to use your rods. Okay, just any kind of motion. Your cones are going to be good for central vision. So where rods are peripheral vision, your cones are going to be central vision. Okay. They're good. They require bright light. They're best in bright light. And they're really good for details or seeing details. Details and colors are your cones. Okay, so cornea, sclera, protective layers, your choroid, your ciliary body are your vascular layers, and your retina is your photoreceptive layer. Okay, 3 different layers of the eye that you need to be aware of. Now, the next part you need to look at, you also have a lens. The lens helps focus incoming light on the retina. And attaching the lens to the ciliary body, you have some ligaments. Draw them in here. These are known as suspensory ligaments because they're just suspending the lens between the two ciliary bodies. These are suspensory ligaments. Okay, so essentially the suspensory ligaments attach the ciliary body to your lens, and you can see that if the ciliary body contracts, you're attached to with the suspensory ligaments to your lens, it's going to change the shape of your lens. So if it contracts, it's going to make it flatter, and if it relaxes, then it's going to round up the shape of your lens. We'll talk about that in more detail. Next slide. In general, we're there. And you should also know that right in front, as an extension of your ciliary body, you have the colored portion of your eye. That's going to exist right here. So this person would have blue eyes. Okay. That's just the colored portion of your eye, and that's going to be your iris. So the dark space in between the two irises, I didn't realize it's going to go all the way around. You're going to have a hole there, and that's going to be your pupil. That's where light actually comes in the eye. And as light comes in, or vision comes in the eye, it's going to go through the lens, and the lens is going to focus it specifically on the area of the retina that has the largest concentration of cones, which is good for detailed vision. Yes, Benson.
For example, I'm nearsighted, so is that like a cause of the ciliary body not contracting correctly, or is it just like a shape?
I don't know the answer to your question because I'm not an ophthalmologist, but I do know that, so I know that as you get older, you become more farsighted because your lens can't round up as much, it gets stiffer. As far as being nearsighted, I'm nearsighted as well. I don't know what the cause of that is. I don't know that it's, I know when they correct the vision, they change your lens by giving you external lenses, right? But what the cause of that is, I don't know that it's a problem with the ciliary body so much, because the ciliary body is under parasympathetic control. We'll get there in a minute. But what causes nearsighted or farsighted, I'm beyond the scope of PT practice. Any other questions? Yes. Sam?
So it's the pupil it's the iris that's going to be the part that's actually like making it smaller and larger.
Good question. We'll get there in the next slide. This is my big 360 overview to start with. I'm just hitting all the important parts. But yes, so Sam's question is it the iris that's responsible for changing the size of the pupil? And the answer to that is there's a couple of muscles that are responsible for dilation and constriction of the pupil. We'll see those in more detail in a minute. Okay. Right now, let's think about if the light is coming in, it's going to be the job of the lens to actually focus in a specific area of the retina. This area of the retina has a very high concentration of cones. Okay, so it's good for detailed vision. And this area is known as the macula. So I'm going to draw it here in purple as part of the retina proper. Okay, the macula itself has the highest concentration of cones in the retina. So this is your macula. And the part of the macula where you want your vision to be focused predominantly is going to be here. Okay, so you have your macula has a very high concentration of cones, and most of those cones are centered in this little dimpled area here, and that's called your fovea, F-O-V-E-A. Okay, so the fovea, let's just say the highest concentration of cones for detailed vision. So it's going to be the job of the lens to focus what's coming in, specifically in the area of the fovea. Okay, other things you need to be aware of is, in addition to the macula and the fovea, way back here where the optic nerve exits the eyeball in the back, there's a space. It's just a hole, and the hole allows that optic nerve to pass through. That hole has a special name. That hole has a special name. It's called your optic disc, and that's what creates the blind spot in your eye. So back here, just this area where I circled, this is the hole where the optic nerve passes through, and that's called your optic disc. And that's responsible for, everybody has a blind spot, your brain makes up for it. That's responsible for a blind spot. Okay. Other parts to consider. Inside here, inside the eyeball itself, it's not hollow, okay? It's filled with a gelatinous-like substance, and that gelatinous-like substance, I'll just indicate it by these dots. It's really a jello-like substance. It's called vitreous humor. So it exists everywhere from the lens all the way back to the optic disc, and it's just a gelatinous-like substance that fills this space. It helps kind of keep the eyeball fluffed out, okay? And it's vitreous humor, V-I-T-R-E-O-U-S, humor, H-U-M-O-R, and that's just a gelatinous matrix inside the eyeball. Bless you.
How is that?
V-I-T-R-E-O-U-S, vitreous humor, H-U-M-O-R. Okay, that's just gelatinous matrix inside the eyeball itself. And then there's another kind of it's an aqueous matrix, an aqueous solution that exists between the lens and the cornea. And this is known as your aqueous humor. So the inside the eyeball, behind the lens, is a vitreous humor. It's a jello-like substance. It keeps the eyeball nice and puffed out. And in front of the lens, between the lens and the cornea, there's an aqueous humor, and that's just a liquid matrix. Okay, talking about things that you might hear about in your clinical future. Cataracts. Does anyone know what causes cataracts? Anybody? Any thoughts? So what happens is with cataracts, there's actually a buildup of crystals inside the lens of the eye. Okay, people are going to have difficulty seeing without really bright light. Okay, if they're driving in the dark, it's going to be really hard for them to see because the crystals that build up inside the lens of the eye actually occlude the light from coming in, just prevent the light from coming in, so it's hard to see. So that's cataracts, yeah?
So it'd be like a fully blacked out spot, like blurry?
No, it's dark, darkened, very much darkened. It's kind of like wearing sunglasses all the time. So if you're driving at night with sunglasses on, it's that hard to see, okay? With cataracts, it's a simple surgery. It's an outpatient day surgery. You go and they take out the lens and they replace it with a new lens. So really simple. Most times patients are going to do one eye at one time and then another eye a little bit later on. They don't do them both at the same time. But that's a very common surgery that you might hear about in your future. Okay, somebody with cataracts, simple fix. Usually happens with age. Some people are genetically predisposed to cataracts early on in life. Another problem that you might hear about is macular degeneration. Has anybody ever heard of macular? Well, there's the macula degenerates. There's wet and dry, two different kinds. We don't need to know what they are, but you need to be aware that if somebody has macular degeneration, what do you think they can't see? Can they not see the periphery or right in front of them? Right in front of them, right? That central vision is gone because the macula starts to degenerate. Okay, depending on what kind of macular degeneration, some individuals might be able to get just shots in their eyes that prevents it from progressing. Okay, so that's macular degeneration. Realize these people, they're going to detect motion really well. Their rods are functioning just fine. It's their cones that are degrading. And so when you're walking with them, they're going to see the motion in the side, but they're not going to be able to see your face or anything in print in front of them. Okay, but they have that peripheral vision still. Another problem you might hear about is glaucoma. You guys heard of glaucoma? That little puff that they give you when you go to the doctor's office. So it actually turns out that this aqueous humor in front of the lens is recycled. It's kind of like your CSF fluid, you know, it kind of goes through cycles. If the area where the aqueous humor drains is clogged, that's what causes the glaucoma. Okay, so just information. Somebody with glaucoma, they're going to present with more of an eye pain and blotchy vision. They're going to lose specific spots of vision. Okay. All right, moving on. That's the structure of the eye. And now on to Sam's question. We're going to look at the control of the lens and the pupil size. And this is what I've done with this picture is I've taken this picture here and I've just zoomed in. So what you're looking at is just this part. Okay, so you have the ciliary body forward because we're going to take a detailed look, a close-up look at what all the structures are here. So this is really going to be your cornea there. So let's put that in there. So here's your cornea. Again, protective layer. Coming forward, you have that muscle structure. So here's going to be your ciliary body bilaterally. Okay, ciliary body. And here's your lens. It's going to be the lens of the eye. And then tethering the lens of the eye to the ciliary body are going to be your suspensory ligaments. And then I'm looking at the iris. There's going to be the iris. I'll keep the eyes colored blue. That's not very good. So here's the iris on one side, iris on the other side. Realize the pupil is going to be that space in between the two irises. So far, nothing new. Inside the iris, there's a couple of muscles that are going to be important for controlling the shape of the pupil. And one of those muscles is going to be here at the very tip of the iris. I realize this is going to be just a transverse section through the eye, so that this muscle is going to go all the way around the opening of the pupil. If you can imagine that, that's just a cross section. So it's a circular muscle that goes all the way around the pupil. This muscle is called your sphincter pupillae. S-P-H-I-N-C-T-E-R, pupillae. Okay, it's responsible. So if that muscle contracts, what's going to happen to the shape of the pupil? Is it going to constrict or get dilated? It's going to constrict, right? So everybody see that? So if this sphincter pupillae constricted or contracted, you would get a shortening, a decrease in size of the pupil. So it's going to be responsible for pupillary constriction.
Can you scroll down?
Spell that again?
Or can you scroll down?
Scroll, yes.
Push down.
Uh-huh.
Thank you.
There you go. Yeah, sphincters, S-P-H-I-N-C-T-E-R, sphincter pupillae. Okay, that's going to be the muscle that's responsible for pupillary constriction. Okay, and then there's another muscle that's going to be responsible for pupillary dilation, and that's going to be right here. You have your sphincter pupillae responsible for constriction, and this is going to be your dilator pupillae. If you can imagine, like I said, this goes all the way around. So if this muscle contracts, then you're going to get a dilation of the pupil. So it's going to increase in size. This is going to be your dilator pupillae. Okay, does that answer your question, Sam?
Yeah, and it's, just to clarify, so those are contracting, making the iris itself move. The iris is like the moving body with it. Okay.
Yeah, the iris, so the muscles inside are contracting and changing the shape of the pupil by changing the size of the iris.
Okay.
Okay? And then there's one more thing you need to know about we talked about a cranial nerve that's responsible for pupillary constriction and lens accommodation. Which cranial nerve was that? Does anybody remember? Yeah, 3 specifically. So the oculomotor nerve and the nucleus, the specific nucleus that's responsible for those parasympathetic innervations. So that's right. So parasympathetic functions for cranial nerve 3 are going to be pupillary constriction and control of the shape of the lens by making the ciliary body contract. That's going to be through the Edinger-Westphal nucleus. Okay, so the Edinger-Westphal nucleus is going to be responsible for both these things. So the pupillary constriction and ciliary body contraction. Okay, so just 2 actions. Both of those actions are parasympathetic. You guys know sympathetic versus parasympathetic yet? Have you gotten that in Biz? Yeah, so the parasympathetic is going to be your rest and digest. Your sympathetic is going to be your fight or flight. Okay, so it actually turns out that the dilator pupillae is under sympathetic control. So it's the opposing action of the parasympathetic. So in other words, if you're being chased by the tiger, you want your pupils to dilate because you want as much light coming in as possible. You want to see where you're going really important. That's going to be a sympathetic action. And that's it. All put together. Questions about that? Makes sense. So you've got the parasympathetic action of cranial nerve, ocular motor, cranial nerve number 3. It happens through the Edinger-Westphal nucleus, and that nucleus is responsible for pupillary constriction as well as rounding up of the limbs. Okay? Yes, Ian.
Can you explain one more time why constriction would be parasympathetic but sympathetic for exactly?
Explain why. So constriction is parasympathetic. That's the parasympathetic action is going to have your pupils constrict. That's just the parasympathetic control. Because the sympathetic control, you want your pupils to dilate so you get more light coming in. So when you're rested and relaxed, you want pupillary constriction. If you're under tremendous amount of stress, you go into fight or flight, which is your sympathetic action, and your pupils are going to get great big around. Okay? That's just one of that's how the eye expresses, I guess, sympathetic versus parasympathetic. You know, there are also there are ADHD medicines too out there that will make your pupils great big around as well, right? So I've seen that often. And there's also another thing that you will see in the clinical setting. If somebody is very well medicated, not feeling any pain with opioids, they're going to have pupillary constriction. Okay, they're super relaxed. That's parasympathetic. So two opposing ends of the spectrum. Any other questions? That's how, yeah, when you have somebody who's in pain management and their pupils are the size of pinpricks and they're asking for more pain medicine, you think, well, maybe you've had enough, right? So, okay, moving on. Next is going to be visual fields. This is going to be really important to understand the rest of the talk. So I try and, having done this for many, many years now, I've learned that this is really important for understanding everything else that's going on. What you see here, these are eyeballs. This is going to be a transverse section through an eyeball. So here's the pupil. I'll go ahead and draw on a pupil here up front. That's the pupil. Okay. And then this is going to be your optic nerve coming out the back end of the pupil. And this is my rendition of a nose. So you're looking down on the eyeball. Okay. This is the right eye, and this is the left eye. So to understand the pathway for visual information coming from what you see all the way back to your occipital lobe, because that's what has to happen. It has to travel through a pathway. This is the start to understanding that. Okay. I'd like to start out with your visual field. To represent visual fields, about halfway through the visual field here by the middle of the nose, this is going to be your total visual field. So in other words, your binocular vision. If you're looking with both eyes, this is what you see out in front of you. Okay, you're going to start here. You have this red on the right side, and then you're going to have the blue. We're going to put blue on the left side. Red for right. Okay, that's binocular vision. That's what you're going to see when you're looking out both eyes, right? You can see everything directly in front of you, and you have pretty good peripheral vision. You can see pretty much to the end. If you put your hands out just in front of your ears, you can still see them, right? They're still there. Now, what does the right eye see? What is the right eye capable of seeing? Okay. To understand what the right eye is capable of seeing, I like to have everybody just take your left hand and put it over your left eye. Now, what does your right eye see? Your right eye sees, or my right eye sees, everything far over there like I saw before, but it only goes just past my nose. If I go, I don't see the far left half of the world when my left eye is covered, right? So, has everybody got that? Does everybody see what I'm saying? Okay, so that means my right eye, this is what my right eye sees. My right eye sees all of the red, okay, and about half of the blue. I can't see with my right eye over on this far side here. I can see maybe about halfway. That's what my right eye sees. So that's my monocular right eye visual field. Okay, same thing happens for the left eye. If I cover my right eye and I look out my left, I see about the same. I see all the way over there on the left, but I can't see the far right side of the room. So that means I see with my left eye monocular vision, I see all this blue, but I'm only going to see maybe half of the red. Everybody see what I'm trying to do here? I'm showing you a visual field. So total is binocular, both eyes together. This is what my right eye is capable of seeing by itself. And then this is what my left eye is capable of seeing by itself. Just breaking it up into simple colors. Now, let's look at the right eye. And I'm going to say that things in the middle are part of my nasal visual field. That's where my nose is. Things on the outside are part of my temporal visual field. That's closest to my temple, right? So nasal visual field, temporal visual field. Does everybody see that? So if I use those words, that's what I'm saying. Let's think about what the right eye sees and how it sees it. So as far as the nasal visual field for just the right eye, we're just working here. I'm going to draw it back and see what happens. If I take this, the nasal visual field is projected to the temporal retina of the right eye. Okay? And the temporal visual field, this up here, the temporal visual field is projected to the nasal retina of the right eye. What happens is those two retina, like we saw in the overview, the retina from this side comes straight on down and becomes the second cranial nerve, the optic nerve, and the temporal retina comes straight on down, and that forms your optic nerve, second cranial nerve. Okay, everybody good with that? Now, looking at the left eye, let's see what the left eye sees. Same thing. The nasal visual field for the left eye is projected to the temporal retina. So here's the projection of this image over here. There's the temporal retina. Comes straight on down. Temporal retina receives the nasal visual field of the left eye, and the temporal visual field is projected to the nasal retina of the right eye. Oh, left eye. Left. Questions about this? Like I said, if you're getting lost when we go forward, I'll come back to this. Let me know, and I'll come back to this and try and explain it again. But for me, it's easiest to see if I have the whole right side of the world in red and the whole left side of the world in blue. Because as we come back from the level of the optic nerve all the way back to the level of the occipital lobe, things are going to change. Okay? All right, let's move on then. This is visual fields. And from visual fields, we're going to go to visual tracts. This should be a 2 T's here, visual tracts. Okay, all I'm going to do is I'm going to do what we just did again. I'm going to look at the total visual field. I'm going to say, first off, this is a transverse section. Here's my eyeballs with the pupil up front. There's the nose. This is my rendition of an ear. ears bilaterally, okay? And back here, this is the occipital lobe. Okay, I'll write that in the middle. So this is the projection of visual information from the eyeball all the way back to the occipital lobe where vision is processed. And when I'm looking at occipital lobe, if you can imagine, this is flipped up. So this is the superior part of the occipital lobe, and then this is going to be the inferior part, the occipital lobe. See that? Okay, superior is going to be up top, up here. Inferior is going to be down here, on the back of the brain. Okay, and this is going to be the right side, and this is going to be the left side. And I'm going to take that complete visual field and just draw it up here again. I have that complete visual field right here. So going from the nose all the way over to the temple. And on the left side we have the blue from the nose all the way over. Okay, once again, looking at the right eye. The nasal visual field for the right eye is projected to the right temporal retina. And the temporal visual field for the right eye is projected to the nasal retina. Just what we did, nothing different. Okay, and for the left eye, the nasal visual field for the left eye is projected to the temporal retina. And the temporal visual field for the left eye is projected to the nasal retina. Same as before. No changes so far. Everything should look exactly the same. Okay, let's start labeling some parts here. As I mentioned previously, just exiting the eyeball, this part is going to be your optic nerve, and that's cranial nerve number 2. And this is something that we saw when we pulled the brains way back when. If you remember, the optic nerve was coming out, and there's this like X-like structure back there that I said, don't cut that. That's your optic chiasm. Okay, this is your optic chiasm. We'll look at it again when we go back into the brains. Now you're going to know what it is. That's your optic chiasm. So optic chiasm is where things can cross over. And then past the optic chiasm turns into something called the optic tract, T-R-A-C-T. So just basic parts of the visual system pathway. And these are very visible in the brains. You can see optic nerve, optic chiasm, optic tract clearly when you're looking at a brain, a human brain. Another part we need to label is going to be the nucleus that's involved with the visual system. If you remember when we went through the cranial nerves, we talked about cranial nerve 1 and 2 being above the pons, 1 and 2, 3 and 4. Well, 3 and 4 we saw the nuclei, but we didn't see the nuclei for 1 or 2. So the nucleus that the visual system or the optic nerve, cranial nerve number 2 uses, is actually a nucleus of the thalamus. I'm going to draw it here. Okay. It's a specific thalamic nucleus that you need to be aware of. It's called the lateral geniculate. Nucleus. Okay, that's your lateral geniculate nucleus. And like I said, this is a thalamic nucleus, so it's part of the thalamus. So, cranial nerve number 2 does have its own nucleus, but that nucleus resides in the thalamus. It is the lateral geniculate nucleus. And thinking about visual system pathway, the temporal retinas are really simple. So the temporal retina here for the right eye just travels straight on down the optic nerve, travels through the optic chiasm, staying on the same side, goes through the optic tract and synapses with the ipsilateral lateral geniculate nucleus. Same thing happens on the left side. The temporal retina for the left eye travels down as the optic nerve through the optic chiasm, staying ipsilateral, through the optic tract, and synapses here on the lateral geniculate nucleus of the thalamus that is ipsilateral. The nasal retina are a little bit more complicated. What's going to happen is the nasal retina for the right eye travels down the optic nerve and crosses over in the optic chiasm. Travels down the contralateral optic tract and synapses with the contralateral lateral geniculate nucleus of the thalamus. Same thing happens with the other nasal. So the left eye nasal retina travels down the optic nerve, crosses over in the optic chiasm, travels down the contralateral optic tract, and synapses with the contralateral lateral geniculate nucleus. Jeff?
So is that why, like, when stroke patients have, or like post-stroke, like you can only see like half of your vision?
We'll get there. Yep, we'll get there in a minute. That's where we're going. That's exactly where we're going. Okay, but realize at the level of the thalamus, you separated all the information from the left side of your world is now at the right thalamic nucleus. Yes, Ben?
Is the only visual feedback range that going to the temporal retina past the point of the regular point of nerve, or is there a range that's
Is the only part, so I guess I'm trying to understand, is the only part, so can you speak up, is the only part of the nasal,
like, is it just past the nose?
Yes.
That's going to the
yes, yes, and that's going to be important, that's important. So yes, if you're visualizing, that's it, that's what you need to visualize, okay? And that's where people get messed up, so keep that in mind when we're going to move forward. Okay, at this point, the right side of the world has gone to your left thalamus, and the left side of the world has gone to your right thalamus. So we switched. Okay? That's where we're going to stop for right now because we need a short 10-minute break, and then we'll come back.